Good morning, ladies and gentlemen. My name is Yulia Smolin, and as the Chief of Staff, I'd like to personally thank the AAMC for their sponsorship of our conference. Furthermore, it's a privilege to introduce our next keynote speaker, a healthcare professional we can all look up to. Dr. James Madara is an accomplished academic physician, medical scientist, and administrator. He currently serves as Chief Executive Officer of the American Medical Association, the nation's largest physician organization. Prior to joining the AMA, Dr. Madara served as Tenured Professor and Chair of Pathology and Laboratory Medicine at Emory University School of Medicine, before assuming the Thompson Distinguished Service Professorship and becoming Vice Chancellor and Dean at University of Chicago Pitzer School of Medicine. Dr. Madara is a noted academic pathologist and authority in epithelial cell biology and in gastrointestinal disease. He has published more than 200 original papers and chapters, making important contributions to understand the biology of cells that line the digestive tract. His work has garnered both national and international awards. Dr. Madara has also served as president of the American Board of Pathology and as editor-in-chief of the American Journal of Pathology. He earned his medical degree from Hahnemann Medical College in Philadelphia and completed his internship and residency at New England Deaconess Hospital in Boston. Let's all warmly welcome Dr. James Madara.
Well, thanks, Yulia, and it's really wonderful to be here. My continual daily aspiration is to be around people no more than half my age, so this is really terrific. And the enthusiasm and energy that comes from a group like this is really palpable. I'd like to talk just a bit about the AMA and how we look toward the future. Now, just in the last couple of months, we've become the global partner of TED-Med. And Jay Walker, who's the founder of TED-Med, always tells me that you should be able to summarize a presentation in a phrase. And for us, that's really easy to do. It's our mission statement: to promote the art and science of medicine and the betterment of public health. Now, we have kind of a complex organization that we bring to this task, but you can think of it as a sum of 5 parts. We have a House of Delegates that makes the policy of the AMA and elects the elected leadership. It consists of all 185 medical societies in the United States, all 50 states, all the specialty societies. And so essentially all physicians in the country are represented in this house that makes our policy, and that's why that's recognized so well in Washington. In addition, there are physicians that choose to be individual members, and they do so for various reasons. Sometimes it's a solidarity reason. Sometimes it's a reason to get things that I will touch on in the next 2 boxes. One of those is practice tools of various kinds to help in practice. Another, in the 4th box, are research and education products, from continuing medical education to, of course, JAMA and our 9 JAMA network journals. We also produce about half of the quality measures that are embedded in the federal government's healthcare program. And then we also have mission areas that I'll talk about a little more in a second under research and education. And lastly, we have advocacy both in the courts and in DC, advocacy to make that mission statement, promote the art and science of medicine and the betterment of public health to become real. So I'd like to talk about 3 big ideas that now drive AMA strategy in the mission area. And I will speak a little more about one of these 3. The first is, how do we connect the clinic to the community to optimize health outcomes? You see, in the last half century, we've gone from disease that been predominantly acute and played out in front of providers to disease that's chronic and plays out in the community. And yet, for these chronic illnesses, we medicalize the treatment inside the healthcare system. When in fact, we need to find better ways of engaging community assets. So we have traditional partners in our work in prediabetes and hypertension. The Centers for Disease Control and the AMA are now coordinating their activities nationally around prediabetes. Prediabetes affecting more than 80 million people in this country, by the way. But we also have non-traditional partners. The YMCAs of America are now our partner. 80% of the population of the United States lives within 5 miles of a Y, and the Y has now changed its strategy from community exercise to community health and wellness, and is rolling out the diabetes prevention programs in connection with the AMA and the CDC. The second major idea is to really change medical education for a 21st century point of view, and I'll talk a little more about that, so leave that for the moment. And the third is to make the practice of medicine joyous again. We, with RAND Health, did a study recently in 6 states, various practices, and what we learned was the single driver that drives satisfaction in a practice is the amount of time the physician has with her patient, and the sense that when the physician goes home, that he or she has done an excellent job in providing health care for the patient. And so the dissatisfiers are anything that gets in the way with that. And things that get in the way with that are workflow issues in practices that are intrinsic, and we're now creating tools to distribute the practices to address these issues, and some extrinsic pressures as well. For example, the electronic medical record. No one wants to go back to paper, but the electronic medical record in its current 1.0 version is optimized for claims and billing and risk mitigation. It's not optimized for the efficient entry and extraction of clinical data needed at the point of care. So we're working with both vendors and regulators in this area. It's interesting to note, for example, that in the certification of electronic medical records by the federal government, there's not a single criteria around usability, and that has to change. So let me go back to the middle topic, bringing medical education into the 21st century. Now, many of you know of the Flexitarian Revolution of 1910, where medicine, which was relatively sloppy in its education at the time, became more rigorous and robust and formalized and was drawn into the university sphere across this nation. And this led to a tremendous change in healthcare in the United States. Someone mentioned the Nobels earlier today. In the first quarter century of the 20th century, there were 0 Americans named as Nobels in medicine and physiology. In that last quarter of the century, there were 42. It shows a huge difference that occurred in medical education at this time. But this system, although the curriculum is updated yearly with new knowledge, the structure largely remains the structure from 1910. And so let me talk about a couple of things that can be corrected and addressed. First is competency versus time in chair. We are in an educational domain currently where competencies can be measured. They're measured in the aeronautics industry, but they're very sparsely measured in the medical education area. So, I mean, just to drive this point home, you know, as a medical school dean, you can fear that when you're with a business or a political leader, you can get these fundamental questions asked. Here, you know, I'm wondering what this leader is going to ask, and being smart, he goes right to the central question, you know, how does Jim know that these graduates are indeed competent? And then when that question is asked, I have to say it's a humana kind of moment. No wonder the guy has gray hair now, you know, facing such challenges from institutions that are thought to be, you know, classic in our country. So we need to shift to a measured competency-based education. We also use outdated educational approaches. The top here is a biochemical reaction, the Krebs cycle. And if there are over 141 accredited schools, there are over 140 lectures on the Krebs cycle. Now, surely, one of those lectures must be the best. And I can tell you that I have personally tasted one of these in the lowest decile, and it didn't feel so well. And you also wonder, do we have to really know the details of the Krebs cycle, or do we need to know in medical education the themes and the principles? Again, things that need to be changed because they're somewhat outdated. The middle figure, talking head to a big audience in a traditional classroom, doesn't fit with educational theory. And when I say educational theory, this has been known for more than 40 years, that this is not the way to educate people. And we're very proud in medical education, the simulation that occurs, but the electronic simulation, the use of avatars and the like, is not what companies that are in the electronic area would think that medical education would be at currently. We're really primitive in using those areas, and we're working with two companies, iHuman and MedX, on the West Coast toward this end. Relatively immiscible faculties, the clinical science faculty, the basic science faculty, these are faculties that have different cadences to their day, to their career, different skill sets, different knowledge components, and they have to be incorporated in such a way, but since they're kind of immiscible, we kind of still keep them separated. We try to mix where we can, and I liken it to shaking a vinaigrette. You know, you shake it really hard, put a lot of energy in it, and you set it down the table, and a minute or two later it's settled out again. And yet, why do we have to have this when we have the electronic platforms that allow intermixed, adaptive kind of education? If you look at the Intro to Biology MOOC by Eric Lander, you'll see that in 6 lectures, you can get the entire principles of biochemistry if you can only have adaptive embedment of subsequent information in clinical cases, and this is what we aspire to. So what are we doing about this? Well, we also have to think about shifting sites of care. That we've gone from sites of care that were largely inpatient to now larger volumes in the outpatient area. And with the advent of telemedicine and digital devices, a tsunami of which are about to appear, there is now much more home-based care as well. So what does this mean? Well, that means we really shouldn't be training our students dominantly in an inpatient environment. It means that we should be training for chronic disease, which means team-based care on one hand, on the other hand, continuity of care. And yet the choppiness of our education to date does not really affect this. So what have we done? We've created a medical school consortium of 11 schools. I was surprised about a year and a half ago, sent out an RFP, and we were hoping to get maybe 6 schools responding. Over 100 schools responded. 85% American medical schools responded. And so it shows the appetite and the general sense that, this is really indeed needed. These schools are geographically diverse. Some are public, some are private. We wanted to make sure we didn't have a sort of a narrow view of this world. I want to point out that UC Davis is one of our 11 schools, and that there is a sub-consortium within our consortium. Brody, East Carolina, Brown, and UC Davis, which is a sub-consortium for innovation in the area of underserved populations and health disparities. Now, each of these schools has a champion dean, has the piece of innovation pre-processed by the faculty. We meet as a consortium frequently. Just a few weeks ago at Vanderbilt, soon in Austin. And each piece brings a puzzle of innovation that, assembled together, gives sort of a vague outline that will become increasingly clear of what a medical school of the future might look like. So why do we do this? Well, we have to think about what medicine will be in the future, and here is just one model view of something that could occur in 2030, although, as you know, these predictions that far out are hard to do. But one could imagine 3 levels of types of care. One being what Clayton Christensen and Harvard Business School would call a solution shop. And that is high technology, complex, primary diagnoses that are complicated, acute interventions, high technology. So that's a high-cost platform and should have layered onto it only disease that requires a high-cost platform, not an intermixed. So this would be kind of like a research-intensive academic medical center with much more focus in this solution shop area. A second would be chronic disease management. We've shown quite clearly that we convert what used to be acute disease into chronic disease that's manageable. That's happened in cardiovascular disease, stroke. Evidence is it's happening in cancer now. So we will have this large group of chronic disease. And they will need their own medical homes that focus on their special problems. For example, my son has Crohn's disease. His medical home is actually a gastroenterology office, but the gastroenterologist should be a little more fleshed out like a medical home. That is, that the parallel activities of nutrition support and the like would need to be embedded to make this sort of a patient-centered home. I think what this also means is when we think about patient-centered medical homes in society producing a lot more of chronic disease, that we're not dealing only with primary care. There'll be a lot of specialty medicine that's practiced, I think, in a way that denotes and feels like a medical home. And then thirdly, and most differentiated, is the health and wellness that we don't really pay as much attention to in our country as we need to. And these will be very large groups with kinds of professionals that you don't even recognize now, risk counselors, individuals that talk about exercise and behaviors. And the leader of this large group is going to have to be someone who's kind of a chimeric trainee between medicine and public health, and also someone with extensive and well-developed management skills. So one could imagine this kind of orientation that would also need these 3 areas to be really well connected, because patients would be moving from one of these domains to the other. So let me just close by saying, and it's been said before this morning, that what an exciting field medicine is today. And it's a field that you really personally connect to. My personal connection with medicine happened when I was in 6th grade playing basketball. Ran into the iron pole holding up the backboard and had a serious complication, a cavernous sinus thrombosis. I was in a little town in central Pennsylvania, ended up being hospitalized for 2 months in Philadelphia. And seeing what went on around me, seeing how my own life was saved, and enjoying that environment is what led me to medicine. Because like you, I aspire to promote the art and science of medicine and the betterment of public health. Thank you.